Welcome to this edition of Medical Minute. I'm Chastity Darfus, and today I'm joined by Dr. Jessica Hott, endometriosis specialist and minimally invasive gynecological surgeon at WVU Medicine. Thank you for joining me today, Dr. Hott.
Thanks for having me.
How are you?
I'm good.
Good. So March is Endometriosis Awareness Month.
Yep.
So can you explain what is endometriosis and who does it affect?
So endometriosis is a disease that affects about 10% of all women, anywhere from the age of 12 to menopausal range. Even after menopause, women can have endometriosis, and it's when the tissue that is normally supposed to be the tissue that's normally growing inside the uterus actually is implanted in other locations. And that causes a chronic inflammatory response that can also affect other organ systems like the bowel, the bladder, and lead to other symptoms, not just symptoms that are related to the menstrual cycle, but other types of pain, pain with defecation, difficulty with urination or frequency of urination. And unfortunately, endometriosis is notably known as a diagnosis that is not seen right away. There's about a 6 to 10 year sometimes gap or delay in diagnosis of women who actually have this, because the only way we can diagnose it is with tissue pathology from a surgical evaluation.
What are some of the symptoms of endometriosis?
So the most common symptoms are going to be pain during your menstrual cycle. A mild cramping is probably more of a normal symptom, but anything beyond that, when it affects bladder symptoms, rectal symptoms, GI stuff, nausea, and then like moderate to severe pain with menstrual cycles is not normal, and those are the most common things that we see. In addition, patients present with pain with intercourse. They present with difficulty having bowel movements, and sometimes even depression, anxiety, and chronic fatigue is also a really huge symptom of endometriosis.
Why do you think there's such a delay in the diagnosis period?
I really think it's the lack of education and the knowledge of what these symptoms are and how they can be mistaken for other pathologies. And, our moms are notorious for saying, oh, I had horrible periods too. Sorry, right. It's just going to be that way. And then we accept that instead of, seeking education or more information about it. And so a lot of times, patients are like, I've had these symptoms for 20 years and nobody said that it could be this. So unfortunately, it can be, many different types of symptoms that we see, and it's never the same. Every patient is very different.
So it's probably hard to diagnose then.
It is hard, yes, unless you have someone that is willing to take you to the operating room and do a diagnostic laparoscopy or use more advanced imaging, where sometimes we can see things a little more detailed.
So as our endometriosis specialist here in Eastern Panhandle, what are some treatment options that you offer for someone with endometriosis?
I think anyone who's suspected to have endometriosis, we empirically treat them with some type of hormonal medication, or at least offer. A lot of people don't want to use hormonal medication, so then we, talk about and encourage sometimes surgical evaluation and resection. I think the biggest thing is that we can suppress endometriosis with hormonal treatment, but the only real proven way to eliminate symptoms that are the result of the chronic inflammation, which is adhesions or scar tissue that forms around these surrounding tissues and organs, is surgical excision. We know that it works. It's been proven. Unfortunately, though, a lot of generalists have never seen these procedures done or have never done them themselves in training, so they're uncomfortable with it.
Right. And
sometimes, there's doctors that don't even know that this is an option. So it's really an advancement in our field that has rapidly happened in the last probably 3 to 10 years.
Okay.
And not everybody's up to speed that how successful or how well excision surgery works.
So I was going to ask, how new is minimally invasive surgery for endometriosis?
So it's not necessarily new, it's just become more sophisticated, right? Okay. With the adoption and evolution of robotics, I think, and even laparoscopy itself allows us to see things more clearly, especially using our Da Vinci Xi and DV5 surgical robotic instruments. It allows us to see things that we really just couldn't see before with traditional laparoscopy. So I think the vision that we have now is better. And then the ability to explore these complex spaces in the pelvis, we can do that now with more ease and more safety.
You talked about medicine as an intervention and surgery. So how do you know which is right for your patient? Who is a prime candidate for surgery versus maybe medication management?
So someone who's failed other types of hormonal medicine and management, I would recommend surgical exploration and diagnosis to get an idea of how bad is it, what's the stage, and where are the locations where it's affecting. Is it involving the bowel? Is it involving the bladder? Sometimes imaging is very limited and we can't see those things until we directly visualize the pathology. You
mentioned that endometriosis can affect someone as young as 12 years of age all the way through menopause. Are there certain risk factors or genetic factors that determine whether or not you'll get endometriosis as a female?
So the sad part is we really don't know. We don't know what causes it. We don't know what makes it worse. We do think that there is a genetic predisposition. So if you have a strong family history, then it's possible you're going to have it. We also think that, we just don't know what is the pathophysiology. We have a bunch of theories and hypotheses of how does endometriosis get where it gets, and some of them make no sense. I've had a patient with a 7-centimeter lung mass recently who presented with a hemothorax, and the pathology of the fluid that they removed was endometriosis.
Wow.
I have had bowel, rectal, bladder. I've had endometriosis multiple places, and a lot of times it's mistaken for other things like IBS or chronic constipation or interstitial cystitis or other bladder symptoms, but it's almost always endometriosis when these patients have these symptoms.
And you can surgically remove that endometriosis from other parts of the body. You're not just limited to the uterus.
Yes, not all other places. I would never remove it from the lung. I would refer that patient to the lovely Dr. Reddy, our cardiothoracic surgeon, but anywhere in the pelvis is my wheelhouse, and in the rectovaginal septum, the pelvic sidewall, the bladder, those places are where I'm very, very regularly removing deep endometriosis.
What does the recovery process look like for someone who's undergone surgery for endometriosis?
So it's the recovery is really a lot less challenging than most people expect because we do things minimally invasive. We make small incisions. Everyone goes home the same day, and pain is usually almost better than before surgery because these patients have been suffering for so long. And so they don't even realize what pain is because they've had such significant pain for so long that their post-op pain is really not a challenge for them at all.
Okay. So we talk a lot in the medical field about a multidisciplinary approach, so incorporating some specialists, as you said, like Dr. Reddy. How do you implement a multidisciplinary approach for endometriosis in your practice?
So for me, I'm very frequently referring my patients for colonoscopies, upper endoscopies, and evaluation by the urologist because of the findings that we see during surgical exploration and excision. So sometimes I'll refer them for these other tests with GI or urology before surgery, and sometimes I do after an exploration. It just depends. But, working together, I think we realize in the community that a lot of patients who we have not necessarily misdiagnosed, but given the diagnosis of overactive bladder or given the diagnosis of interstitial cystitis, they actually may have endo. So the other subspecialists have now incorporated some other screening questions to their patients that have those symptoms, and they are evaluating them now for, well, what are your menstrual symptoms like? And do these symptoms that we're worrying about, are they worse when you're on your cycle? And surprisingly, they're hearing yes more frequently, and then they refer those patients to me, which is great.
Good. Do you think that has improved patient care in the region now that we're becoming aware?
I do, and I think that's one of my goals with the new practice is to really expand the education to our other providers and even primary care docs who don't realize that some of these symptoms could be related to endometriosis.
Do you want to tell us a little bit about your practice?
Yeah, so we've gotten the opportunity to really focus on more surgical consults and get more people seen for specifically endo and also pelvic organ prolapse and urinary incontinence. And a lot of the complex GYN cases that we used to send out, I'm able to do those now here locally. and we've been super successful. I'm about to do very close to doing my 500th robotic surgery. I have not had any, we have not had any major complications or reoperations for any type of surgical complications, which is really something to be proud of. We've pretty much discharged 99.9% of all of our surgical cases on the same day. So they've all been outpatient surgery, and we're really proud of that. And the ability to maximize and be more efficient in our new office space with more rooms so that we can get more patients seen and evaluated than we used to be able to do.
Awesome.
Yeah.
Can we talk a little bit about robotic surgery? You've mentioned it a lot. Tell us some of the advantages for the patient, laparoscopy versus robotic.
Yeah, so for me, I have a lot of surgical autonomy, so I'm doing a lot of the retraction or manipulation of surrounding structures myself with my extra arm, because I get to have 3 arms during surgery when I use the robot. And so I feel like I can be safer and I can be more efficient, and my dissection can be more meticulous because I'm able to do that for myself. I also think the camera is hands down, it's phenomenal. Now I look at traditional laparoscopy and I'm like, I feel like I probably missed so much because the camera that we use is high definition. It is HD, it's 3D, so everything is 3-dimensional as well. And things that are the size of a quarter look like they're the size of a dinner plate with my robotic eyes. So it's really allowed me to evolve and advance through that complexity spectrum of gynecological surgery to be able to offer some of these brand new and the most newly innovative procedures that we could do. I'm able to do them now.
That's amazing to offer to this community.
It's really exciting.
Is there anything else you'd like to touch on for someone who's watching on endometriosis, warning signs or words of advice, wisdom?
I think words of advice, I would say, if it's not normal, then come see someone like myself or someone else that you feel could refer you to a specialist. I want to also empower providers to know that they can send some of these patients our direction so that we can help them. And I think not giving up and realizing that there is hope out there, and that just because you haven't gotten that diagnosis yet doesn't mean that it won't happen. So I think educating your friends, educating your family. I have patients all the time that are like, oh, I told my neighbor that I had these symptoms and you found endo and now they're coming to you. And so it's really nice to see that the community is educating themselves, but I want it to be more of a presence for us to be able to educate the community and let them know what resources and options that we have available for people suffering from this relentless disease, because it's really sad. I think the most common things that we hear from every patient is they have felt like they've been gaslit, or their symptoms have been dismissed, or they aren't taken seriously. And so, because I guess as women, we're really tough and we're able to just consistently function and just keep on keeping on, even though it's really affecting your quality of life. And so to be able to feel empowered, to seek some type of intervention that we have, and hopefully we can help more people.
Are there online resources that you recommend?
There's a lot of online resources. There's a couple of Facebook pages. There's something called Nancy's Nook where people used to be able to go and find surgeons. The reality is that we think, and this is data that was presented in a research article last year, that there's about 30,000 gynecologic surgeons that exist in the United States, but only about 300 people actually excise endo. And out of those 300 people, only about 30 to 50 people have been vetted by their colleagues and have had their surgeries watched or videos watched to say, yes, you're actually really good at this, you're safe at this, and you're doing the right thing. Okay. So there's only about 30 to 50 people nationwide who are doing some of the things that we're doing right here in Berkeley. So that's kind of cool.
Great. That's great. Yeah. Well, thank you for joining us today.
Yes, thank you for having me.
Thank you for joining us on Medical Minute, and we will see you next time.